Well, good afternoon. Um, my name is Reg Haight. I'm a neurosurgeon in Atlanta, Georgia, spine surgeon. And on behalf of the Chuck Noll Foundation for Brain Injury, the American Association of Neurological Surgeons, and the Neurosurgical Research Education Society Foundation, we'd like to invite you to the first of our series of seminars. We've actually been here for a few minutes talking about Pittsburgh Steelers football, Michigan State, Notre Dame football, Big Ten versus SEC. So we really welcome you to this inaugural event. Let's set the stage. I'm a practicing neurosurgeon. I spent time in Pittsburgh in the mid-'80s. I played college sports. I suffered concussions. And I had the opportunity to serve on the scientific advisory board of the Chuck Noll Foundation for Brain Injury. In addition, I've had the honor to be the chairman of the Neurosurgical Research Educational Foundation and the president-elect of the American Association of Neurological Surgeons. What's happened is this collaboration has formed a great triumvirate. And Mr. Art Rooney, who is the president of the Pittsburgh Steelers and the chairman of the Chuck Noll Foundation, has subsequently asked us to get involved in this educational seminar. This is a kickoff event. So we've tried to strike middle ground here. We know that there's a wide variety of people with an interest in concussions. These come from moms and dads of high schoolers and middle schoolers. I've got 6 kids, 6 grandkids. They play sports, they play contact sports. Every week we're asked about on-field assessment, return to play. In addition, we've all been involved with the Department of Defense, Special Forces, and the military. So with our combined backgrounds and interest in head injury and a lot of concussions in sports, we thought there's a lot of importance to get good information out there. Obviously, in today's world, there's a lot of misinformation. So what we've done is assemble a team of experts on this. And so today, we're very, very lucky to have Dr. Mickey Collins and Dr. Anthony Kontos of University of Pittsburgh Medical Center. These guys are world-renowned experts. These guys get it. They've traveled the world. They've worked with New Zealand and Irish rugby football teams. They've worked with professional athletes across all disciplines, college athletes, middle school kids, right? And these guys are tremendous researchers in the treatment and the evaluation of concussion. So today in our kickoff event, we want to set the stage. We want to talk about what is a concussion? What about treatment? In subsequent formats, what will happen is we'll talk about on-field assessment, return to play, profiles of concussion, types of concussion, things that affect us each and every day. And this broad variety will appeal to a variety of people. It'll appeal to parents, therapists, trainers, coaches, and clinicians and researchers.
Hello, thank you for joining this educational webinar. I'm Art Rooney, president of the Pittsburgh Steelers and chairman of the Chuck Noll Foundation for Brain Injury Research. We are proud to be partnering with the American Association of Neurosurgeons and the Neuroscience Research Education Foundation in presenting today's session. The Chuck Noll Foundation for Brain Injury Research was launched in 2017 to fund early-stage research focused on the diagnosis and treatment of brain injuries resulting from sports-related activities. Our vision is to diminish the impact of sports-related head injuries. The foundation was named in honor of Steelers' legendary head coach, Chuck Noll, who was committed to having a deeper understanding of player safety, especially concussions. To date, the foundation has funded $1.5 million in 10 promising research projects and will be funding additional research projects in the very near future. Today, you will hear from 2 outstanding researchers that the foundation has funded and are proud to partner with. On behalf of the Chuck Noll Foundation, we thank you for being part of this webinar.
Hello, I'm Dr. Anthony Kontos, and on behalf of myself and Dr. Mickey Collins, we are pleased to be with you today and share a presentation, What is a Concussion? From Awareness to Treatment. We'll be happy to take questions after the presentation.
Good afternoon. On behalf of the UPMC Concussion Program, the Chuck Noll Research Foundation, it's a real honor to present to you today on the topic of concussion. We are making a lot of advances in understanding this injury and in treating this injury, and I'm here to share with you our increased knowledge in the space. Before starting, I do want to disclose that we've written a book on this topic. I was previously a co-owner of Impact Applications, and we also have a lot of grants supporting our research. None of these conflicts will have any role in the current presentation, however. All right, the objectives of the lecture this afternoon is I want to teach you about the pathophysiology of this injury and then share how that pathophysiology leads to different types of concussions, and then how we actually treat those different types of problems that we see from concussion. So here's a typical concussive injury that we see. When a concussion occurs, what happens is the brain moves within the skull. And when the brain moves within the skull, the membrane of the neuron will stretch, and potassium, which is supposed to be inside the cell, will leak out of the cell, which increases the demand for glucose or results in hyperglycolysis. At the same time, calcium, which is supposed to be outside the cell, will leak into the cell across that same stretch membrane and result in vasoconstriction and decreased cerebral blood flow. So in essence, at the very time the brain's demanding more energy, we actually have a decrease in cerebral blood flow, and there's a mismatch between supply and demand of energy. Now, fortunately, that returns to normal fairly quickly, where the potassium will go back in the cell, the calcium will go back out, and the permeability of the membrane will come back to normal. We actually do not see cell death from this. But that energy problem that occurs, we've actually found leads to certain systems in the brain that can decompensate from that energy problem. We recognize that there's different symptoms of this injury and different types of presentations a long time ago. But it's just been recently where we've been able now to identify that there's specific problems that we'll see from concussion. And the advances that we're making are really secondary to the fact that we now are treating the aberrant signal. Like, where is this actually coming from? Knowing these advances, we convened a meeting in Pittsburgh back in 2016. It was the first ever meeting on the treatment for concussion. And at that meeting and through our program at UPMC, we've now been able to identify that there's 5 different specific clinical profiles of concussion. These include migraine, cognitive issues, vestibular problems, ocular motor deficits, and mood-related deficits. Now, patients may have one of these circles after an injury, or they may have all 5, but treating where the problem is coming from is way more advantageous than treating this injury in a one-size-fits-all way. I often say that treatment of concussion is about process, it's not about protocol. And understanding your patient's specific problems is critical to treating those problems. Now, you can see here that neck and sleep issues can play a role with concussion, and they often do, but they're not primary profiles that we'll commonly see. They're influencers, if you will, on the injury. Now, once you identify what type of concussion you have, there's different treatments for those different problems. And you'll see here that if you look carefully at the slide, you don't see rest very commonly listed. And that's because rest doesn't typically treat the problems that we see from concussion. Let me briefly go through each of these different profiles to share with you how we approach this injury. For migraine, which is common after concussion, we, in a behavioral way, patients will benefit, you can treat migraine in patients by light exercise. You treat migraine by making sure they're not napping, that have a regulated sleep schedule, that they're not stressed out. We don't want patients we don't want their phones taken away, for example. We don't want them sitting and ruminating in a dark room about their symptoms. We actually want them to be external, to be engaged, to not be stressed, to keep up in school. We don't take kids out of school with migraine because it leads to more stress by falling behind. We want them to be around their friends. We want them to be around their teammates. Stress, napping, not exercising makes migraine worse. And so we want to make sure we kind of take an active approach to that problem. In patients with vestibular dysfunction following concussion, you do not treat vestibular problems by rest. In fact, you have to retrain that system to get it better. patients that have vestibular dysfunction after concussion, they'll report the slow, wavy, dizzy. They'll dislike busy environments such as shopping malls or grocery stores or car rides. They won't like busy hallways. The vestibular system is responsible for interpreting motion and movement. It stabilizes our vision, we move our head. And the way we treat vestibular dysfunction is actually by retraining it. And so rest actually can be disadvantageous to getting patients better from concussion. In fact, rest will make outcomes worse in patients that have vestibular dysfunction because you actually have to retrain that system. For oculomotor dysfunction, you don't treat that by rest, you treat it by retraining. We want patients on their phone. We want patients in school. We want patients studying their math and their science and trying to keep up with their coursework. Now, you'll see headaches in those patients. You'll see fatigue in those patients. You probably want to take rest breaks, or you do want to take rest breaks. You want to recover to that problem. But at the end of the day, we have to treat oculomotor dysfunction by retraining and rehabilitation as well. For the anxiety profile of concussion, if you have someone that's anxious and there's no vestibular problems, then we push activity hard. We want them working out in dynamic ways. We want them pushing through their symptoms. Again, with anxiety, don't let them fall behind in school. Don't let them nap. Make sure they're social. Make sure they're external and not internal. We commonly will see anxiety following concussion. Our goal is to treat that in a very active way. And for cognitive dysfunction, cognitive fatigue is a type of concussion that we'll commonly see. We found that light exercise can help that as well. Structured breaks can help, etc. So the common misperception of rest and avoidance is not the way you treat concussion, and it's very critical to understand that. It also is important to treat concussion in a multidisciplinary way. This injury can get very complex quickly, and you want specialists that are trained to treat vestibular dysfunction. You want trained exertion specialists. You want trained concussion specialists in treating this injury. Here at UPMC, we have about 18,000 patients a year, and under one roof, we have exertion therapists, vestibular therapists, physical medicine and rehab, physiatry, psychiatry, primary care, orthopedic surgery. Specialized care is where concussion care is heading. You need to see a specialist for concussion, someone who's trained in understanding the different types of concussions and can provide individualized and targeted approaches at treatment. That is becoming more and more common around this country, and it's important to seek that care out. How do we assess concussion? Well, we do it in a multi-domain way. Concussion is not shown on a CT scan, or it's not shown in an MRI. It's not shown in blood work. Advanced imaging modalities don't show this injury. So therefore, we've had to create tools to measure the injury. And we have very sensitive and specific tools that have been approved by the FDA to measure concussion. Neurocognitive testing, impact testing is one of those tools. That needs to be augmented with looking at the vestibular and oculomotor system. Now, we've created a 5-minute exam called the VOMS. It stands for Vestibular Oculomotor Screening. That does a very good job assessing vestibular and oculomotor deficits after concussion. When you combine impact and the VOMS and the right interview and working patients out to see where things are breaking down, we can assess this injury in a highly sensitive and specific way. But again, it takes a specialist to know how to look at those tools and implement those tools to understand where the aberrant signal is coming from and how to get patients, how to understand what profiles are occurring. Another issue to consider with concussion is that concussion fights dirty. Whatever you bring to the table is often going to be made worse following concussion. We've learned through our research that patients with a history of car sickness are more likely to have vestibular dysfunction after a head injury. That means they have a weak vestibular system. Patients with strabismus or amblyopia are more likely to have oculomotor dysfunction. Patients with learning disability are more likely to have cognitive problems. Patients with migraine have migraine. Patients with anxiety get anxiety after concussion. It's often not how hard you get hit in the head, it's what you bring to the table when you get hit in the head, not only that determines if you have a concussion, but the type of concussion you sustain. We've done research now looking at which profiles of injury are most likely to occur, and we find that anxiety, believe it or not, is the #1 type of concussion that we'll see after concussion. And with anxiety, I think that's likely secondary to a lot of the misinformation that's out there. It's likely secondary to a lot of clinicians are telling patients to rest too much following concussion. But we also feel there's a lot of biology to anxiety after head injury. For example, the vestibular system, the same pathways in the brain that mediate that system mediate mood and anxiety as well. So we commonly see patients with vestibular dysfunction that have anxiety following concussion. Now, the second most common type of concussion is migraine. The third most common is vestibular, followed by ocular and cognitive. That was research that we've done recently showing the prevalence of those different types of concussions. How often do which profiles are most likely to overlap? As I talked about, you don't usually have just one type of concussion. You can, and we see that, but commonly you'll see these profiles overlap. And we've done research now looking at which profiles are most likely to overlap. For example, in our research, we found that patients with oculomotor dysfunction, they're 5.7 times more likely to have cognitive dysfunction as their secondary profile. Patients with migraine are more likely to have vestibular dysfunction. Patients with vestibular dysfunction are more likely to have migraine. And we know that, and this is the most, 11.2 odds ratio, very strong relationships between these different types of problems we see from concussion. And lastly, if you have anxiety as your primary profile, the most likely secondary profile is going to be migraine. You'll often see in patients that don't have concussions, patients with a history of car sickness are more likely to have migraine. Patients with a history of car sickness are more likely to be anxious. Patients with anxiety are more likely to get migraine, et cetera. And so there's very strong comorbidities that go on with this injury, as we commonly see even in patients without concussion. In summary, there is a lot of progress that we're making with this injury. This is a 15-minute lecture. I'm looking forward to getting into more detail, but the reality is that we now understand there's different types of concussions, that you need to apply very targeted and active treatments for those different types of problems, that certain risk factors drive the different profiles, that this injury is really becoming a specialist injury. The knowledge is advancing so rapidly that you want to go to a specialty care clinic for care for concussion. And those clinics need to be housed in a multidisciplinary way in terms of treating the problems that we see. One of the last points I want to make here is that concussion is treatable. It is very rare that we see patients come through our clinic, even if they're months out from injury, even years out from injury, where we can't get them back to the sports that they love safely and effectively. A lot of the misinformation that's out there about concussion drives poor care, which then leads to poor outcomes. If you apply care early, you can get outcomes that are faster and better, and you can get kids back to the sports they love quicker and sooner. Thank you very much for your time today. It's a pleasure to lecture on this topic, and I hope we can build on that in the future. Thank you very much.
Hello, my name is Anthony Kontos, and I'm the Research Director in the UPMC Sports Medicine Concussion Program in the Department of Orthopedic Surgery at the University of Pittsburgh. Today, I'll be talking to you about our clinical profiles model and the approach to concussion from awareness to treatment and looking at the evidence supporting that model. First, a couple disclosures. I'm the author, along with Dr. Mickey Collins, of the book Concussion, A Clinical Profiles Approach to Assessment and Treatment, and my research is funded by the sources listed there to your right, but I have no conflicts to declare related to this particular presentation. In today's talk, I will be reviewing the following 3 topics, and the objectives therein will be for us to examine the role of risk factors on recovery time following concussion, and also to look at one modifiable risk factor continuing to play in its role on recovery time, and then finally, looking at emerging evidence for the effect of getting athletes into specialty care sooner rather than later, and its role on both recovery time and impairment. First, we will look at the role of risk factors on recovery time. We wanted to look at whether or not there was a dose response or additive effect for risk factors on recovery. In other words, if you had more risk factors, did that make it more likely that you took longer to recover? When we talk about risk factors, we can look at both pre-injury and post-injury risk factors. Pre-injury risk factors such as age, gender, concussion history, or migraine history are not really modifiable and are things that you necessarily bring to the table, so to speak. In contrast, post-injury risk factors are things that happen immediately or in the days and hours following the injury, such as post-traumatic amnesia or loss of consciousness, or perhaps having a higher symptom burden or migraine-specific symptoms. So we wanted to do a study looking at these factors and their role on recovery time. So we looked at 316 athletes aged 12 to 23 years, so spanning adolescence and early adulthood athletes, and we assessed pre- and post-injury factors, including the ones I just mentioned on the previous slide. We then followed athletes to determine whether or not they were medically cleared for return to play per current consensus guidelines, and we looked at whether or not they were recovered at weekly intervals, starting in the first few days following injury. And what we found was that the more risk factors athletes had, the longer it took them to recover. And in this case, we looked at a long recovery as 21 days or longer. And we have three groups represented here in these circles in this graph. First, on the left are a group of athletes with no risk factors or low risk. In the middle is a group with one or two risk factors or moderate risk. And on the far right is a group with 3 risk factors or more, and they're considered a high-risk group. And we move first to the left. In the low-risk group, 97% of these athletes are recovered within 21 days. So they don't bring much to the table or have a lot after the injury to suggest they're going to have a longer recovery. In contrast, if they have just 1 or 2 of these risk factors, 65% of these athletes are recovered within 21 days. And we see a much larger bite out of that apple by the time we get all the way out to 3+ risk factors. And now less than 1/3 of athletes are recovered at 21 days. And in fact, when we follow those athletes further out up to a month, we find that less than half of them are recovered at that time point. So the take-home message, the more risk factors you have, the longer it takes you to recover. Now, one risk factor that's modifiable and that was not included in the previous study is continuing to play. And we wanted to look at whether or not if athletes continue to play, does that result in a longer recovery time? And surprisingly, this was something that had not been done until we published a couple studies, first in 2016, and then again a couple years later. And we really were focused on this particular risk factor because it's modifiable. In other words, you can change this. The current culture of concussion in sport is one of hiding, ignoring, or minimizing the effects of this injury. And there's also a general lack of awareness among many athletes, particularly younger athletes. In fact, there's such a lack of that, or maybe an ignorance of it or a minimizing of it, that 44% of athletes in a recent study reported that they continued to play even though they had symptoms that were suggestive of a concussion. So we wanted to look at whether or not if adolescent athletes continue to play following a concussion, does that really make things worse? In other words, do they really take longer to recover? So we conducted a repeated measures design study with 130 athletes that were in that adolescent age range of 11 to 19, so your typical high school athlete. And we wanted to look at if they continued to play, yes or no, and then how long they continued to play and the association of that on recovery time. Interestingly, more than half of the sample reported continuing to play for at least a few minutes. In fact, 24 of those 130 athletes reported continuing to play for less than 15 minutes, whereas 32 reported continuing to play greater than 15 minutes. And 52 reported that they were removed immediately or were observed to be removed immediately. The primary outcome we were interested in this study was recovery time and whether or not they were recovered by 30 days. The primary findings suggest that continuing to play resulted in twice as long recovery time. Specifically, athletes who continued to play took around 44 days on average to recover, in contrast to those who were removed, who only took 22 days. So it literally doubled the recovery time. And if you look at the comment below the graph, you'll see that athletes that continued to play with a concussion were nearly 9 times more likely to have a protracted recovery greater than or equal to 21 days. So interestingly, we were presenting these data a few years ago to some football coaches in Western Pennsylvania. And one of the coaches said, so based on what you said, it's okay if they play just a little bit, right? And I looked over at Dr. Collins and I said, that's a really good question. And we decided to go back to the drawing board with this same sample to determine whether or not the amount of time you play affected how long it took you to recover. And also so we could come back to that coach and give him an answer the next year. So in this follow-up to this study, which was published in this past year, 2020, we wanted to look at whether or not longer play resulted in longer recovery. And in fact, it did. Those athletes who were removed immediately took about 19 days to recover, which is what we saw in the earlier study. Those athletes who played just for a few minutes, as little as 3 and as much as 15, so not very long when you consider a whole game, soccer, football, whatever, they took nearly a month to recover, and they were 5.4 times more likely to take 21 days or longer to recover compared to those who were removed immediately. And in stark contrast, the group that played the most, greater than or equal to 15 minutes, took 44 days to recover, and they were 12 times more likely to take 21 days or longer to recover than the immediately removed group. So here we have evidence for the first time of a dose response for continuing to play on longer recovery time. And so now we could go back to that coach and say, hey, think of concussion as sort of like a sprained brain. It's better to sit out now for a week or two than to keep playing even for a few minutes and risk sitting out for a month or longer. Remember, 45 days, which is how long it took those players that continued to play for 15 or more minutes, can be more than half of a season in a high school sports season. Finally today, I'd like to touch on some emerging evidence looking at the importance of early specialty care. In other words, once you're told you have a concussion, how important is it that you seek specialty care for that injury, just like you would for an ankle sprain or a knee injury? Now, the reason we did this study is there continues to be a gap in concussion care here in the United States. In fact, nearly 60% of athletes following a concussion, an initial diagnosis, do not seek specialty care. That results in about 2.2 million athletes in the United States each year not receiving proper care following a diagnosis of a concussion. And that may lead to the 600,000 individuals each year, athletes that is, that develop persistent post-concussion symptoms. So we wanted to conduct a study to look at what is the role of time from injury to first clinical visit on concussion recovery time. And this was published in the journal JAMA Neurology this past winter in 2020. So we conducted a study with 174 athletes aged 12 to 22 years, and their primary predictor in this study was the time to first clinic visit. And we dichotomized or divided that into two groups. A group that got in within the first few days or the first week following injury, and a group that didn't get in until about 8 to 20 days later. The primary outcome we were interested in was recovery time. And again, that's per the consensus criteria for medical clearance for full return to play. And we looked at a group that recovered in under 30 days and a group that was 30 days or longer. We looked at other measures as well, including demographics, symptoms, cognitive testing, and vestibular oculomotor screening to see how well those predicted recovery when added to how soon they sought specialty care. And the results were stunning. The late clinical care predicted longer recovery. In fact, it was the strongest predictor of all the factors that we considered. The only other significant predictor was history of migraine. And if you look at this table, what you see is that late clinical care, when you adjust for all other factors, including history of migraine, resulted in a 6.2 times greater odds ratio for a longer recovery than those who got in earlier. So athletes seeking care late were 6.1 times more likely to take 30 days or longer to recover. And with history of migraine, it was 3.1 times, so about half the effect that we have from getting into care late. So if athletes seek care sooner, they have an earlier return to both sport and school or academics. They mitigate potential negative effects associated with rest and isolation, both socially and from school and other things. And this also reduces the healthcare burden and utilization costs associated with this injury. Some key takeaways from my talk today. There's a clear dose response effect for risk factors on recovery time. Those with 3 or more risk factors are at significant risk for a longer recovery. And those with very few or no risk factors recover much faster. Continuing to play, a modifiable risk factor that we should all be paying attention to, is important to consider, as there is a dose response there also for recovery time. And finally, athletes who seek care earlier get better faster. So it's important, following an initial diagnosis of a concussion, that athletes seek specialty care in a clinic. Research like this doesn't happen in a bubble or by myself. All these people listed here contribute to it, and I would like to thank each and every one of them for their contributions. And finally, I'd like to thank you for your time today. And if you have any other questions or for more information, you can contact me at the email listed on your screen. Thank you.
If you have a patient that has anxiety as a primary profile, I would strongly argue that you do not want to give accommodations, because we need to treat anxiety by exposure. And then you don't want them falling behind in school. We've had very poor outcomes in patients that come to us that have been overcompensated for school, and they fall behind and don't address the issues head on. So it may seem a little counterintuitive, but there's some patients I'm going to push really hard to get back to school without accommodations, and some patients I'm going to be very careful. It depends on what type of concussion and the severity of it.
Well, thanks. You know, I always had trouble with physics and calculus, so maybe that came from my concussions as a kid.
It's entirely possible, but you're also a neurosurgeon. So.
Well, we're not that smart with our hands. So Joe Maroon sent something in, and so before people leave, we have a lot of panelists. I'd just like to say that our next series will include profiles of concussion, evaluation, treatment, on-the-field assessment by people like Dr. Maroon and Dr. Okonkwo. Our future moderators will be Shelley Timmons, who is the chairman of neurosurgery at Indiana University. The football team's not so bad this year. And Shelley's past president of the American Association of Neurological Surgeons. We'll have David Okonkwo. David is the chair of the trauma section for neurosurgery. He and Dr. Maroon, who's a past president of the Congress of Neurological Surgeons, are team physicians for the Steelers. And Dr. Maroon and Collins developed the impact testing. So going forward, we'll actually give a demonstration of the impact testing. We'll give a demonstration of the BOEMs, things like that. While we're waiting on some other questions, Anthony, I've got a question. You talk about the risk factors. You said the 3 or more risk factors, they had a longer recovery. You mentioned the pre-injury risk factors, right? Age, gender, concussion, and migraine history. Can you unpack that a little bit in terms of age, gender first? Are females more susceptible, like female soccer players? Is it hormonal? What's the ages? Can you help us unpack that some?
Yeah, so for age, what we see is kind of a curve that you see limited risk early on, so younger kids, but then in adolescence is where we see that risk peak. So like my 16-year-old daughter who had a concussion, like a year ago, she had some issues with that. She also happened to have migraine history and some motion sickness. And so that made her concussion a little more problematic than someone. In fact, my son had a similar concussion, and he lacked some of that history. And so it was a little bit different. He was also a little bit older. So when you get up to college age, you see that risk start to dip. And I think the important thing is to think of it as an additive risk. So the more of those you bring to the table, the more likely that your recovery is potentially going to be prolonged. When we look at females, that's a risk factor, but it also may be covering up some other risk factors. They're more likely to have migraine and some motion sickness as well. And so there's other factors that are playing a role with female. The literature on hormonal stuff's a little bit limited. I wouldn't necessarily put a lot of salt in that just yet.
Okay.
I would say that's about it.
So should schools, like I've got 6 kids, they play, college sports. My 2 youngest daughters play middle school soccer. My grandsons play soccer. When and if should teams gather risk factors pre-season? I mean, do you start every season with looking at history of concussions, migraines? Is that overkill? Will the coaches accept that? Will the trainers accept that? The whole thing's changed. When I got knocked out, it was called ringing your bell, and you went back and played. I was at a Notre Dame Oklahoma game for rugby a couple years ago on the sidelines, and the Notre Dame rugby player came off the field, said, "I may have been concussed. Will you test me?" Which was so when Joe Marin and I played, we wanted to hide the concussions. It seems like now kids have an awareness, families have an awareness. Can one of you guys or both of you guys speak to that?
Well, I think that awareness is really good. And you saw in our data through our program that if kids come out of play, their outcome is going to be much faster. You don't want to play through a concussion. We know it's going to last to a longer outcome, and it's going to be disadvantageous to get better quickly. And it's quite striking the amount of difference we'll see if kids come out of play when they first get symptoms. There's a big difference in outcomes. So I applaud that awareness. I do think the culture is changing a little bit. I think that the knowledge is better. I think there's an awareness that this is an injury that needs to be taken seriously. And those are all good things. But awareness with no solution could be hysteria too. And we got to be careful with providing the right information out there. This is a treatable problem. You just need to get it treated.
So can you tell us a little bit more about when somebody should come off the field? Is it because people used to think concussion is being knocked out? It's not, right? So can you talk a little bit about, until we get into our next session, about recognition on the sideline of concussions, can you give us a little bit brief intro about that until we present?
I'll give you a response from our research that we published several years ago, and then Anthony can build on that with some other studies. But we did a study about 10 years ago now, 8 to 10 years ago now, where we looked at all the on-field symptoms and signs of concussion. And we looked at which symptoms and which signs best predicted patients that took the longest to recover. And on the field, if you had on-field dizziness, you were 6 times more likely to have a worse outcome than any other symptom. And that dizziness that we see with concussion is not like this rapid spinny roller coaster. It's typically more of a slow wavy dizziness, which represents the vestibular system, the central vestibular system decompensating. And that's, we'll have this like dizzy, slow wavy feeling one step behind, disassociated, detached, or foggy. That set of symptoms really predicts patients that are going to have the longest recovery following injury. In fact, we found that loss of consciousness was actually protective. We actually found patients that lost consciousness recovered faster from injury. And the reason for that is because that's a symptom that everyone recognizes and they don't put them back to play. And so, but with dizziness, it's a symptom that can be hid, and then patients try to play through that, and then the outcomes are far worse. So, yeah, and Anthony, you want to build on that with some more recent research we've done?
Yeah, I mean, Reg, to your point, only about 10% of concussions will involve any kind of loss of consciousness. And, there's a lot going on with this injury and what you can see that's obvious, but the problem is when it's not obvious, and making sure that those players are getting evaluated when there's a suspected concussion, making sure that evaluation continues on into the clinic. And one thing to also consider is that a lot of these concussions don't present initially. They may be delayed in presentation by a day or two. And so it's important to evaluate these athletes in the days subsequent to a big hit or, the initial early symptoms.
Can you talk to us a little bit about incidents? So now when you go to high school football games, there's doctors. I know all of my partners were all involved as team physicians, right? And when you go to college club sports now, I mean, when I played at Notre Dame, they had no physicians. Now there's physicians and trainers, et cetera. When I go to my daughter's middle school soccer games, there's nobody there. So there are parents there. So can you tell us a little bit about incidents of concussions between boys, girls, football, soccer, et cetera? Just give the audience some rough estimates there.
Yeah, I think, there's a lot of conjecture that, it's football and to a lesser extent it's soccer or maybe rugby, wrestling. And that's true. Those sports are high risk. But, when we look at girls soccer and girls ice hockey have a higher sort of per capita rate than boys. So the way those sports are played, or maybe the identification's better or something, but we see a little more higher risk in those sports for girls than boys. Obviously, football doesn't have a boy-girl sort of comparison there. But when we look at those sports, a lot of it has to do the injury risk also with technique, behaviors on the field, and really good recognition and awareness of the injury among players, coaches, and personnel on the sideline that are medical and otherwise to make sure those kids get out.
So there was a question here about, somebody said, thank you, Mike Callahan, is there some resources online, et cetera? So what I like to do is, this opening seminar was proof of concept, right? I mean, the Chuck Noll Foundation has supported this. Mickey and Anthony have made their careers out of concussion. The neurosurgical societies, we want to be at the forefront of this. So we really want some feedback about this. And our goal was, if there's interest, if this is worthwhile, we'd like to continue this series by expanding it, creating a syllabus, putting up on websites. My thought is potentially create an app such that when we're on the sideline and somebody gets hurt and gee whiz, I can't remember what that test is. So it may sound a little simplistic, but I think education. So if you talk to Art Rooney, his focus of the Chuck Noll Foundation is on research and education, which is the focus of the neurosurgical societies and the NREF. So hopefully going forward, these experts that we've been so honored to have here and other experts in neurosurgery, concussions, treatment, et cetera, will be able to provide content online that can be easily accessed. Mickey and Anthony, before we sign off, do you have any comments about that?
I just want to say thank you for the opportunity to present. Thank the Chuck Noll Research Foundation. Thanks to Mr. Rooney for providing the medium to talk about this injury and educate. There's just so much misinformation about concussion, and I'm hoping the information that we presented today and what we're going to build upon here is going to dispel a lot of that information. I want to end by stating that, again, this is an injury that we've made tremendous progress in terms of how we approach it and how we treat it. And there's just a lot of misinformation out there. So I'm really excited about this opportunity to be part of this, and thank you.
Yeah, and I would just add, I'm looking at all these questions. I'm typing as fast as I can to answer the 5 or 6 that are still waiting for me here on like the instant message. And they're great questions, and we're going to try to get to those. And I would also say that, one of the things we really prided our program in is letting the evidence drive what we do with patients and how we interact with athletes and others. And hopefully that's where the field heads, where it's an evidence-based approach to assessment, treatment, and really understanding the injury and treating it.
Well, so Chuck Noll, besides winning several Super Bowls, 4, I think, really got together with Dr. Joe Maroon, one of my colleagues and really a father figure and mentor to me. And they started actually looking at concussions and head injury in athletes way before anybody else did. So I'd like to thank Art Rooney and the Steeler organization, the Chuck Noll Foundation. I'd like to thank Mickey and Anthony. This is not going to be the last time you're going to see these guys. So what we'd really like to do is to have questions posed to us, topics, et cetera, because there is a lot of misinformation out there. And what we hope to do in a very logical fashion is continue this journey together. We continue to learn every year. We're looking at such things as on-field sweat tests to assess for head injury. So the research that the Chuck Noll Foundation, the NREF is funding, is applicable on-field daily clinical research. So on behalf of the Noll Foundation, the AANS and NREF, we'd like to thank you. We will forward this to all participants, and please feel free to reach out to any and all of us. Have a great afternoon, and thanks so much. Bye-bye.
Thanks, Red.
Thank you.